Welcome to Eldercare Illuminated, Torchlight's caregiving podcast. Eldercare Illuminated addresses the ins and outs and ups and downs of caring for your loved ones. Join us for interesting conversations with eldercare specialists, geriatric care managers, attorneys, and ordinary people with extraordinary caregiving experiences.
Hello, caregivers. Welcome to this episode of Torchlight's Eldercare Illuminated podcast. I'm your host, Lenore Tracey, and today we are speaking with someone in one of the key specialty areas in the eldercare sphere, speech pathology. Many people think about speech pathology or speech therapy as a service that is recommended to children for issues such as stuttering or a lisp, but that's way too narrow a definition. Today's guest is a speech therapist whose primary focus is on seniors. Julia Haffer is a clinical speech-language pathologist at a rehabilitation hospital here in the Boston area. Welcome, Julia.
Thanks for having me today.
Julia, can you start out by giving us a broad understanding of what speech pathology means in the context of eldercare?
Definitely. So the role of the speech pathologist in eldercare is an important one that, as you mentioned, not many people are aware of. As speech pathologists, we evaluate, diagnose, and provide interventions and supportive care related to many different areas that are impacted through various disease processes, but also as individuals age. So these include areas such as the ability to speak, to communicate, understand, to utilize cognitive functions like memory, as well as the area of swallowing or swallowing disorders called dysphagia.
How did you become interested in this field?
So during college, I first became interested in studying aspects of language and neurology. And it was also during that time that, unfortunately, a close relative of mine was diagnosed with a brain tumor that resulted in severe language and swallowing impairments. It was through that experience that I first learned that there is something out there called speech pathology, so I began to explore it a bit further.
Was that as an undergraduate that you began to do that, or what kind of training?
So yeah, that was as an undergraduate. I started to just learn a little bit about the profession. And then after I completed my undergraduate, I applied for graduate programs, and I attended a 2-year master's degree at the University of North Carolina in Chapel Hill, where I obtained a degree in speech and hearing sciences. So the 2-year master's, barring the need for any prerequisite coursework, is currently the standard in the field for clinical work. And then after that, I completed a nationally mandated 36-week clinical fellowship program. So that's where you begin to practice under supervision until you ultimately obtain what's called your C's. So it's 3 C's, and it stands for the Certificate of Clinical Competence. And that's what anyone practicing in speech pathology needs.
When you started out, did you work with both children and elderly people?
So during graduate school, you do have the opportunity to work across the lifespan, partly to gain experience, but also to learn a little bit more about what area you might be most interested in working in. So I actually thought I was going to want to work with children, which is why I began to study this area in graduate school. But it was through some of the adult-focused trainings that I really discovered my interest in working with the older population. And then that's where I began. When I started my clinical fellowship work, I did an acute care hospital, and then I've continued to work in the hospital and adult settings since then.
I know that there's one big focus of your work is stroke recovery, and that involves both communication and swallowing issues. So what are the tools, what are the methods you use to help someone whose speech has been compromised to regain some of their capacity? And also, you said earlier that what you do is not just about speech, but it's about understanding. So how do you approach someone who's been affected by a stroke?
Yeah, so stroke is definitely a diagnosis that I see frequently. And at various levels of care, I work from the acute care to the skilled nursing, so at all different stages of the disease process. An important distinction to make here is just to think about the difference between what we call speech and what we call language. So speech refers to the ability to articulate or make sounds, and when this is impacted, it can be called something like dysarthria or apraxia, depending on the specific type of impairment. So this could result in someone having very little to no sound output, or more mildly to just speaking in a way that's slightly less precise or less clear to a listener.
And is that about your mouth and the muscles in your mouth and throat?
It can be about the mouth and the muscles and throat for sure, if those muscles were impacted by the stroke perhaps. But it can also be about the motor planning, so the brain telling the mouth and the tongue and the lips how to move. So even though the muscles have good strength and good movement, that signal from the brain to the mouth of how to move just isn't getting there.
Which for us, without a problem, we don't think about that. You said planning. None of us, you and I, are not thinking about that in what I think about as planning. So this is all something that happens automatically. What's happened when someone has a stroke?
Exactly. So when someone has a stroke, depending on where it is in the brain, it can have a very different impact in terms of what function, whether the stroke's on the left side or the right side, whether the stroke's in a particular region. Speech can be impacted, but so can language as well. Language refers more to not so much how we're saying something and how the sound is, but the words that we're using and how those words are structured. And that can be written language, it can be spoken language. So a term people may have heard before is something called aphasia, which is a language disorder. And again, this can result in someone having very little ability to communicate. It can also be much more mild. That person might speak very fluently, meaning they speak full sentences quite completely, but it's just not making sense, or it's not totally clear what their message is. Or they might be what we call non-fluent. There's far less communication going on. And really all of this is coming from the brain, which makes sense because that's where the stroke has happened. But depending on the particular region, there's some connections that have been disrupted, either in the language pathway or the speech pathway. And that's what we're trying to work to repair.
When somebody has a language problem and they may be speaking fluently, but it's not what the listener is hearing, doesn't make any sense. Is the person hearing it correctly or hearing what they intended in their own mind? Or are they, and I may be asking you questions you can't answer, of course, or are they hearing what the outside listener hears?
That's a good question, a good point to make. So yes, I mentioned the, what the person is saying or what they're not saying, but the aphasia, the language disorder, does also impact understanding of communication. That can be one's own understanding, as you're mentioning. So it's not unusual that someone who's speaking in seemingly full sentences, but making very little sense, might not actually recognize that they're not making sense. And similarly, they may not understand what is being said to them. A little bit like, akin to being in a foreign country. You're hearing language and you know it's words, but it's just not making sense to you in the order that you're hearing it.
But it sounds horrible and frustrating for the person who's experiencing this. So what do you do when you are beginning to work with a patient who's having issues like this? What does the speech pathologist do?
It's definitely very frustrating, both for the person trying to communicate as well as for their caregivers who are trying to communicate with them. So the first step is always to, of course, figure out what type of aphasia they're having. Are they understanding? Are they not understanding? If they are, it's usually on some spectrum or gradient. Maybe very simple language is making sense, but anything beyond that isn't, or somewhere on that continuum. And then depending on where that breakdown's occurring, there's different therapeutic interventions that will target those areas. Oftentimes a combination of exercise to try to rebuild some of those neural connections and strengthen the, what we call semantic or word meaning networks. But also spending some time establishing ways to make the most of communication right now. So trying to, of course, improve, rebuild, regain, but also find ways to communicate with what is currently available. Whether that's by using strategies or alternative methods of communication. One example of an intervention some people may or may not have heard of through the media with people like Gabby Giffords is the use of music, or what we call melodic therapy or melodic intonation therapies. For some people with some types of aphasia, going in a different pathway and accessing the language or the musical parts of the brain rather can help be a tool on which language can be mapped and verbal communication can be mapped to help regain some speech.
So what would that look like when you were working with someone? If that's an approach you take, what does that look like if I were to watch you working with someone?
So if you have someone who's appropriate for what we call this melodic intonation therapy, you might start with something as simple as tapping their hand on the table to a rhythm and then starting to hum out that rhythm. Like let's say we had a 3-note sentence that was our target, like I love you. You might start by doing 3 hand taps and then maybe 3 hums with a varied intonation. So, and then you'd kind of get them into sync with you for that after a couple turns, and then you'd slowly map on some words to that. I love you. And you might do it in unison. You might fade yourself out and try to have them continue to carry that over. And then the ultimate goal, of course, would be to carry that over on their own and to eventually fade out the melodic portion of it and have it be just natural speech of, I love you, when prompted to get that phrase.
That's pretty amazing. So most of our listeners are caregivers and caring for an elderly loved one, whether it's a parent or an aunt or uncle. As friends or family members, what can we do that builds on what you're doing to help someone with some of these types of communication problems?
Definitely. I think, the role of friends and family is extremely important. Therapy is important, but we're one small piece of the whole puzzle, and friends and family are there 24/7. I think certainly patience and emotional support are really important. As we mentioned, this is something that's really frustrating for the person trying to communicate. So being as patient as possible and supportive it goes a long way. Participating in the therapy sessions is also definitely encouraged. That way caregivers can see what works. They can see what doesn't. They can learn the best strategies and support methods. It's one thing to hear this description, and I've just given you a description of what that might look like, but it's hard to actually conceptualize that until you've seen it and been a part of it. And then on the flip side, it's also helpful to have friends and family there to help the therapist best get to know your loved one. After a stroke or a communication change, the person may not be able to share things about themselves that we'd want to know of who they are and what motivates them and what's important to them. So that's an important role too for friends and family to play.
That sounds very important. And one thing I noticed when I asked you to share an example, you shared this musical example with the words, I love you. And obviously that says to me that one of the things that you are trying to do or that's going to be effective is making some emotional connections. So you're not going for, the chicken crossed the road. You're saying something that's going to be meaningful to the patient. That's got to make a big, big difference. How long does it usually take when you're working with someone who's had a stroke? And I do appreciate that there are, obviously great variations in how severe the stroke might be, but it's kind of your average patient. Do you work with them in rehab? How long do you work with them?
So that's a good question. The interesting thing about my role is I do work in different settings. So I will sometimes see the same individual travel from the acute care hospital where they were when they first had their stroke, when they start their therapy, go to rehab, and then continue on, whether it's an outpatient therapy from home or a skilled nursing facility if they're not, physically or medically able to be back home. I oftentimes see people for a duration of, anywhere from 2 to 4 weeks, but that's a small piece in their entire recovery process. And I always try to make that really clear to clients and to family that, even when we're done, because you're leaving rehab or you're leaving a skilled nursing facility, the therapy's not done. It continues. It's a long road for many folks, even 6 months, a year, or longer, depending on the severity of their impairments, their desire or motivation to continue, and of course, availability and access to therapy through things like geography, insurance.
Sure. And do you typically, during the acute and rehab phases of recovery, does a speech therapist typically see someone every day? Physical therapy is typically every day. Is speech therapy an everyday kind of thing?
Oh, that's a good question. It does depend on the level of care that you're at. Most acute hospitals or skilled nursing facilities, you might expect to see speech therapy at a lower frequency, maybe a few times a week, once or twice a week at the acute care, 3 to 5 times a week at the skilled nursing facility. At an inpatient rehab facility, it's much more common to see the 5 to 6 time a week therapy because of the level of care that person's at. And then once people go to outpatient, it is far less frequent. And that's where you start to transition either home care, outpatient care to, it shifts a little bit to the client and the caregivers to be doing a lot of the work and practice, and the therapist is there to help facilitate and promote progress along the way, but it shifts to definitely be more on the client and the caregivers at that point.
Yeah, and practice probably makes a huge difference.
Exactly.
If someone loses speech completely, and I guess that you can verify whether that actually is a thing, what options are there for developing new ways to communicate?
Yeah, it is definitely possible to lose speech completely, or speech or language. As we've mentioned, there's a little bit of a difference depending on how we look at it. But there are certainly ways of communicating that don't require speech. So when speech alone is impaired, and again, that referring to the ability to make certain sounds, assuming someone has good language skills and some basic cognitive skills, they can learn to use other methods. And these can range from really simple, low-tech things like writing or pointing to letters on a board to spell words, to much more high-tech devices like a speech-generating computer or an app that can be controlled by various methods like touch, a laser pointer, or even just through eye gaze alone. So we called these methods AAC, or alternative and augmentative communication. Going back to the example of language or someone with an aphasia, some of these same types of things can be helpful depending on to what extent language is or isn't impaired. So for example, if a person can recognize words and pictures but can't adequately express them, they might be able to use a system that allows them to indicate through pointing or gesturing to words and pictures what it is that they're trying to communicate. So there are definitely options, and that's something important to start even early on, even as recovery is happening.
So when we think about Stephen Hawking, that must have been a computer that generated speech.
Yes, that's what we'd call a more high-tech AAC.
Yeah. So in addition to the speech and language issues, and I keep forgetting the language part, but that seems equally, if not more important, if you don't have those skills. There are the swallowing issues that people may have, not just with stroke, of course. Are those always obvious? What triggers you to evaluate, and how do you evaluate someone's ability to swallow?
Yeah, that's a good question. Also a big piece of stroke and many, many other, illnesses. And they're not always obvious. So some things that are important to consider are awareness and knowledge of someone's disease process or their neurology. That's some of the medical information that we think about when we're considering whether someone's at risk for a swallowing disorder. But then in terms of the caregivers, there might be signs that are very obvious of swallowing difficulty, like someone who's always coughing or choking when they try to eat or drink. That being said, some people do have trouble swallowing without feeling it, and they might not have those same outward signs when eating and drinking. There can also be less overt signs, like a disinterest in eating, someone avoiding specific foods, weight loss, or recurrent respiratory infections. Those can all be, maybe slightly more subtle signs that there might be some swallowing issues going on.
Yeah, definitely. Those are hints. My mom had difficulty swallowing in the advanced stages of Alzheimer's disease, and that wasn't something that you could see during the eating process, but we noticed that she was keeping the food in her mouth, so that things weren't going down, and it never seemed to kind of complete the act of swallowing and eating. And of course, weight loss is a huge tip-off. So if a caregiver notices something like that, whose attention do they bring it to? Whether if someone's at home, it's going to be more difficult than if they're in a facility. I imagine professional caregivers would notice it. So if you've got your mom or dad at home and you're noticing things like this, what would you do?
I think, sharing the concern with a primary care physician, or if you're in a situation where you have a visiting nurse coming into the home, sharing it with, a care team member. It can be a physical therapist coming into the home, to be quite frank. Anyone that you feel is someone who is on your team and could potentially help advocate for you. And then it's important to know that this might be a time to say, I think my mom or whomever it is needs an evaluation with a speech pathologist. So I think it's important to know what to ask for. Yeah.
What does the evaluation for swallowing issues look like?
So we'll always start, and again, this is true of whether we're in the acute care hospital or the home care setting, we'll always start with what we call a clinical swallowing evaluation. So that would involve gathering all of the relevant history information from the individual, the caregivers, the medical team or record, looking at their medical status, looking at their face and throat musculature, and then ultimately, hopefully trying various food or drink items in different ways to get some information about what might be working or what might not be working. And is there any recommendation that we can make from there to help make things easier or better or safer? If more information is still needed, there are 2 often used instrumental swallowing studies that can be completed. One is called a FEES, and this stands for Fiber Optic Endoscopic Evaluation of Swallowing.
Sounds scary.
It sounds a little bit scary. Hopefully it's not actually too scary. It can be slightly unpleasant. It does allow a small endoscope to be passed through the nose into the upper throat. And the swallowing and the upper airway muscles can be seen in action. So it actually lets us watch as an individual is eating and drinking different things, what's happening, where's it going. And then the other one is called a video fluoroscopic swallowing study. Non-invasive, so far more comfortable. And this is a moving x-ray where, again, the individual is eating and drinking. The items have what's called barium so that the swallowing can be seen on x-ray. And again, we're looking at how the swallow is working, what's happening. And it also gives us an opportunity to trial different interventions. If we think something might be helpful, it's a really good time to explore that.
So do you show up with 12 little cups of different stuff? Get into the nit and grit of it. What are you actually asking people to swallow if you're trying different things?
Yeah, so it could be anything. So we're talking about solids and liquids pretty much. And liquids, we all know, are normal liquids that we drink. We call them either regular or thin liquids. But there are other liquids that are thickened, which can be of benefit for some people with swallowing disorders. And those can be what we call either a level 2 or a nectar thick or a level 3 or a honey thick. So just getting thicker, more viscous can sometimes be easier to swallow. And then for solid food, we also have sort of a continuum of texture ranging from what we call our regular food, meaning anything and everything that we all eat, crunchy, coarse, dry things, down to slightly softer solids that are really finely ground up and diced, and then all the way down to pureed solids. So completely smooth and blended, things like yogurt, mashed potatoes, cream of wheat. So oftentimes on that clinical swallowing evaluation and through the other evaluations, we're trying liquids and solids that are amongst those range of textures because that may either be beneficial or less beneficial for swallowing depending on the texture for that individual.
And so you might end up with a prescription kind of for the patient saying, like detailing what kinds of foods will work better and what kinds might be problematic. That's pretty interesting. I found it to be totally counterintuitive that when I was working with my mom, that it's harder to swallow water or cranberry juice than to swallow a milkshake or a chocolate frap, as we might say here in New England. What's that about? Because I think people by and large think, oh yeah, the easiest thing is going to be the most liquid and fluid.
Yeah, it's true. It's true. And, swallowing is something sort of like you mentioned before with communication, we don't think about. We sort of take for granted and we don't, really think about what makes it easy, what makes it hard. And for some people, liquids that are very fast moving, like a thin liquid, if you picture pouring water out of a glass as opposed to pouring maple syrup out of a glass, it moves much faster. And for some people, if there's an issue with the timing or coordination or strength, they just might not be able to manage that or handle it in a way that they can either control it in their mouth adequately or allow it to pass through the throat in a way that isn't too fast and it accidentally goes down the wrong pipe, as we've all experienced, into the airway, what we call aspiration, meaning it just went down too fast and down the wrong way.
And that's a dangerous thing.
It can be.
To aspirate food or liquid. When I was preparing to talk to you, I did a little looking around on the internet and I saw on there some apps that you could download to use at home on your own, which maybe that's a good thing, maybe it's a bad thing. What do you think about internet apps for speech therapy?
I think these can be a really great way to allow people to continue working on specific skills outside of therapy time. We sort of talked before about how, especially once you get towards more of the home care and the outpatient, but just in general, it's never quite enough therapy. People always want more. They always need more. So it's a really good opportunity to continue that, especially as we in society now get more used to using tablets and computers and smartphones. It's just a really familiar way in which to work. That being said, I think it's important to know what you're addressing by using a particular app and to do some homework into the efficacy of the claims they might make. I don't think there's much concern for harm with these types of things. It's just important to know what the potential benefits might be before spending a lot of money on an app. There's a lot of game type apps that we use in therapy to target specific skills, and they can be a really great resource.
I think we talk about gamification of all sorts of things, but if you have to practice a skill that you didn't ever realize you had, or be planning these complex activities that you never thought about that just happened automatically, I suppose if it's a game, it can make it more fun. It could make it less boring to do, and practicing will increase skills.
Definitely a lot of good research for frequency. Yeah.
Yeah, because it's like making kids practice the piano or practice the violin. If you can make it more fun, it's going to be more successful in getting them to spend more time at it, and time on task improves success rates. So I like to ask therapists who are providing services to families, what are the things, or what is the one thing or the few things that would make your job easier when you're working with a patient, that the patient's family can do for you or do with you to make what you do more successful and more effective?
Yeah, that's a really good question. I don't think it gets asked that often, so it's an appreciated question. There's certainly a few things. I think continuing to reiterate the importance that I mentioned before, being involved in the therapy process. It's not like a drop off and leave and come at the end type service. It's helpful to be able to understand the why and the how of what's going on so that you can best know how to carry out some of those exercises and strategies and understand why you're doing them. It's also helpful to be present so that you're an advocate to relay important information to the therapy team that, again, related to communication impairments, your loved one might not be able to do successfully or accurately. It's also great having family there because they know their loved one the best. So certainly, we don't want families to hesitate to speak up if we as therapists are missing something. That being said, it's also important to recognize that, unfortunately, many times your loved one is maybe not the same exact person or having the same exact behaviors that they were before their disease. So it's important to be flexible and maybe try some therapeutic approaches that are recommended that might not be something you would have thought initially might have worked.
Yeah, so to be open-minded about...
Open-minded, yep.
Are any of the apps or the games that you bring into work with the patients, are any of them ones that the family can get involved with also?
Definitely, yeah. And I think that's one of the benefits of this type of thing is it's something that is usually pretty user-friendly and pretty easy for family to help carry over. So it's a good way for them to be able to help facilitate some therapy without having to be a therapist and have, all the innate training and knowledge if they can just help to, get someone set up and carry out the practice.
And if it's fun for the family also, it's more likely to get done. Kids ever get involved with any of these things, working with their grandparent or aunts or uncles? Do you ever involve kids in it?
Oh, yeah. Yeah. I've definitely had, grandchildren or, nieces and nephews who are visiting who, again, because they're of a younger generation too, are a bit more excited sometimes about these apps and games and things, but it can be a really good way to get the whole family involved and to keep some of those connections too. I think that's the other important thing I like to remind family of, it's great to help with the therapy and to carry it out, but ultimately, you're their family and you're their friend. So still continue your role as family and friends. We can do the drill work and give them challenges and exercise them, but it's helpful to just be a companion and have some normalcy with family. And sometimes this is a good way to have a little bit of both. You have that quality family time, but you're still working on something towards a rehab goal together.
That's really, really good advice. And caregivers often struggle to remember and to remain in the role of the daughter or the niece,
Right.
or
Right.
just a family member who cares. And so it sounds like you can introduce potentially some fun and enjoyable activities that are also providing really important therapeutic results.
Definitely. Yeah. And having that caregiver relationship and that normalcy is also so important. It can be certainly a frustrating and, sometimes demoralizing process for people to be trying to rebuild skills that once came, as we mentioned, without a second thought. So it's really important to have some of that normalcy that family time can provide.
I think that recognizing that makes a whole lot of sense. Well,
Mm-hmm.
Julia, I've learned a lot, and I think that your profession is kind of hidden in elder care, and I'm glad to introduce you and some of the things that you do for people to the caregivers that listen to this podcast and that we work with at Torchlight, because it really
Definitely
does take a whole range of skills and types of people and people working together to help us as we age. So I want to thank you, Julia, for being with us.
Well, thank you for letting me talk about our important and often unknown role. So I appreciate that.
Yeah, we shed a little light on it. And I want to thank our listeners for joining us on this episode of Eldercare Illuminated. If you want more information about communication issues, eating, nutrition, and other aspects of caring for your loved one, and you have a Torchlight account, log in and check out some of the e-guides and tools we make available to help you help your loved one. And if you don't have access to Torchlight as part of your employer's benefit plan, but you'd like to, ask your employer to check us out. Our contact information is on our website, www.torchlight.care. And with that, I'll say you all take care now, and we'll see you on the next episode of Torchlight's Eldercare Illuminated podcast.
Thanks for listening to Eldercare Illuminated, a Torchlight caregiving podcast. Find other episodes of Eldercare Illuminated on iTunes, Spreaker, and Podcast Go. If you're interested in bringing Torchlight Elder or any of Torchlight's other caregiving products to your workplace, please contact info@torchlight.care. That's info@torchlight.care.